As the weeks of lockdown progress and the number of people who have fallen ill with coronavirus disease continues to increase, many are concerned with the numbers of hospital beds, ventilators, and healthcare workers on the ground needed to care for so many critically ill patients. But if there's a silver lining to the massive numbers of COVID patients they're seeing, it's that the sheer volume is allowing them to begin to recognize subtle patterns in this disease. Patterns in symptoms that are yielding clues to COVID diagnosis, and patterns in disease progression that are helping doctors understand when a patient who seems stable might take a sudden turn for the worse. I'm Gretchen Kuda-Crowan, and I'm the senior editor of Practical Cardiology. On Wednesday, I had the chance to sit down with Dr. Nir Uriel, a cardiologist from Columbia Presbyterian Hospital in New York. Dr. Uriel and his colleagues are right in the thick of the coronavirus epidemic here in the United States. And they just put out a paper in the American Heart Association journal, Circulation, detailing ways in which COVID-positive patients are presenting with cardiac symptoms, in some cases without cough, fever, shortness of breath, or any of the respiratory symptoms that are considered hallmarks of the disease. It was a fascinating discussion that leads to many more interesting questions and underscores the fact that this disease doesn't look the same in everyone. So learning how to diagnose and treat it effectively presents a unique and unprecedented challenge for physicians. Take a look. And welcome, and thank you very much for taking the time to talk with me today, Dr. Uriel.
Thank you very much for having me.
Okay, so as we have been talking about, there are COVID-19 tends to be, what we think of as a disease that presents itself as a respiratory illness, but we're finding more and more that there's a lot of patients that are showing up with cardiovascular presentation, and in some cases, what doesn't even appear to have any respiratory symptoms at all. So, can you give me a little bit of a sense of what kinds of different presentations of symptoms that you're seeing in different types of patients?
Thank you very much, Gretchen, for this question. And this is actually a very important point. We all, in the beginning, perceive COVID-19 as a respiratory illness, but more and more patients come into our attention with symptoms that are outside of the respiratory system, from gastrointestinal, myalgia, and other symptoms. But in specific, I want to focus on the cardiovascular manifestation that we see among those patients. And as you referred previously, we just published a wide variety of encounter with patients that have different approach. It can be very tricky to understand what is actually the patient have. Patient can come to you with chest pain, changing in the EKG, and elevation in the troponin, something that immediately will raise our concern to acute ischemic event or something else. However, we know today that the COVID-19 may affect itself actually as a myocarditis with changes in EKG that can mimic ST elevation MI with elevation of the ST segment, elevation in the troponin, and the chest pain. And while we see in so many people, every patient that comes to your attention right now with those symptoms should be considered as a COVID patient. And you need to ask yourself whether the symptom is driven by cardiovascular manifestation or by the COVID itself. On the other hand, we can see also different type of exacerbation of cardiovascular manifestation. For example, a lot of our patients have heart failure, and heart failure expresses itself as a shortness of breath. This is the classical symptom that the patient will say. When a heart failure patient will acquire the COVID-19, first of all, the disease may manifest itself harder, and we know that heart failure is a risk factor to a harder disease in those patients, but also the symptoms may mimic each other. And we can see ourselves patients that will come to you with an exacerbation of heart failure, what will be called due to shortness of breath, and chest x-ray that can sometimes be tricky and may be thought to be a fluid overload and can be actually infection with the COVID virus. On the other hand, we can see multiple arrhythmia affecting those patient heart. We see arrhythmia that is actually, the most common one is actually sinus tachycardia. Patients just have a very high heart rate with a normal rhythm. However, we see more and more atrial tachyarrhythmia, atrial fibrillation, atrial flutter, and we can see also ventricular tachyarrhythmia, accelerated idioventricular rhythm, ventricular tachycardia, and others. So the COVID-19 effect on the heart is something that is a wide and affect all aspects of cardiovascular. The last thing that I want to mention is another manifestation that people think a little bit less, but COVID-19 seems to be associated also with increased risk of thromboembolic phenomena like DVT and pulmonary emboli. Again, represent itself as shortness of breath. But eventually the reason for the patient to have those DVT or PE may be the COVID-19 in a hypercoagulable state that may be associated with it. So what are we doing? How can we challenge this when a patient is in front of you? How do you differentiate between the two? And
Right.
this
I
is
mean, it sounds like there's definitely a real challenge here for diagnosis when you have something that, a few weeks ago, a few months ago, you would have, diagnosed completely differently than physicians are doing now.
Yeah, I think that in general, that's what medicine is all about, the flexibility to adapt to what is common at that specific time and to analyze the symptoms and the sign that the patient is giving you and to create a differential diagnosis. Today, in every differential diagnosis that we are evaluating, we need to add COVID-19 as part of the differential diagnosis, specifically if you're in an endemic area. You're talking to me, I'm sitting in New York City. Definitely, this is something that needs to be considered. But this process have to be part of your evaluation of the patient, since we are seeing more and more, exactly as you said, a cardiac manifestation that presumably should have been only cardiac manifestation, but eventually it's a viral manifestation of the disease.
Now, you're seeing a lot of patients in New York. So, I mean, as terrible as that is, at least you are maybe getting to see some patterns. And so I'm wondering if you are seeing patterns here with patients who have, heart failure versus patients who have, coronary artery disease versus like other types of cardiac patients that you're starting to be able to, distinguish some differences, some key differences that you say, wait a second, we should be thinking about COVID right here, as opposed to what we might think is, a myocardial infarction, for example.
I have to say you're 100% right. The more patients you see, the picture became more clear and clear to us that there is different pattern. In medicine, in a lot of what we do is something that based on what we call evidence-based and experience and collective data that have an epidemiological pattern into it. We are in a process of reviewing our own data and learning from all those thousands of patients that came across New York Presbyterian. But until that comes, we can only share the personal experience when seeing those patients. And definitely we can identify some pattern. Heart failure is a significant part. I have to say that in the beginning, maybe you can think that heart failure patient continue to be heart failure patient. Almost, we are following a very big heart failure practice. Today, when a patient will call us with shortness of breath, and with several more few questions, I think will raise a very high index of suspicious. What are those questions? And of course, the community setting. Today, we understand that the community transmission of the disease, we're not only asking about traveling anymore, is something that is a key. Any patient that will have any household or neighbor or something next to them that may raise a concern. If the patient will experience some changes or additional symptoms that are outside of the heart failure itself, for example, change in the appetite, change in the ability to sleep, exacerbation of the symptom overnight, this is something that can trick us a little bit to think, wow, do we really rule out COVID in this patient? So I'm 100% with you, and I will probably be more happy to give you some more insight on that. We'll finish analyzing all the data. As you saw in the last patient paper, we already start to group in our patient to different types. And this is what the idea of it was. Actually, the first type is, as a cardiology, one of my basic tools is EKG. The first thing, someone come to me and said, I have a chest pain, I will do to him an EKG. And I will understand whether or not there is EKG changes that concern me. What I'm learning right now, that significant amount of the COVID patient have EKG changing. The majority of them, non-specific, but it can be EKG changes that definitely mimic, but there is some nuance. The ST elevation MI that we describe, or the ST elevation that we describe in the first case in the paper you refer to, is going all across the myocardium. something that will be more classical of perimyocarditis rather than ST elevation myocardial infarction. So whenever you see perimyocarditis, we're in a COVID pandemic time, you better think that this may be COVID, and that's the reaction that was done in the first case. On the other hand, a patient that is in hemodynamic collapse as the second case, meaning patient that come into the hospital definitely have a COVID-19 disease with respiratory syndrome, and now develop hemodynamic collapse, we should understand that the cardiovascular system is involved. There is a vasodilatation of the blood vessel and reduction of the function of the myocardium. This may be associated to the cytokine storm that we can see in significant amount of those patients that have the severe part of the disease. And we need to address the myocardium exactly as we address the respiratory system. What does it mean? In the respiratory system, we give oxygen. If it's not enough, we eventually can put the patient on a mechanical ventilator. In the cardiovascular system, if the cardiovascular system collapses and the myocardium is depressed, we can medication called iron drops patient, a medication that actually try to create more power to a failing myocardium, like dopamine, dobutamine, sometimes pressor that will increase the blood pressure. However, when this is not enough, we need to give mechanical circulatory support to those patients. And in the first two cases, it was given in two different types. One was intra-aortic balloon pump in order to help augment the function of the heart. In the other case, it was much more severe, and the function of the heart completely suppressed with dilatation of blood vessels. We had to put the patient on a ventricular VA ECMO and a veno-arterial ECMO device in order to take the load of the heart away until the heart is recovering. It was impressive for us to understand that we don't need to give a lot of myocardial support. This patient, probably with some modest myocardial support of 2 liters, you saw in the second case, can overcome the viral cytokine storm that he was at. So definitely we need to address the cardiovascular system exactly as we address the respiratory system.
So let me just clarify here, it sounds like it's not just, we have one piece, which is the diagnosis, and we're sort of learning more about how to diagnose, but also learning that within these different types of patients with cardiovascular disease, that there may be different ways of treating them that are not necessarily going to be exactly the way we would treat them if it was solely their cardiovascular disease that was happening, but we need to modify those treatments to be more effective for their COVID disease. Do I understand that correctly?
I think it's maybe, let me refine it a little bit. What we need to do, the cardiovascular system is affected in a way that we need to support it. The way that we are supporting the cardiovascular system is pretty identical to other cardiovascular collapse if they happen. However, we learned that there is different nuance here. And the nuance, as I said, for example, if we have myocarditis that causes cardiovascular collapse and require VA ECMO from H1N1 influenza, we usually have a complete collapse and we need to give a lot of liters of support while we put in those patients on VA ECMO. On the other hand, here, minimal experience that we experience right now, so we need to take it with a grain of salt. We don't need to give so much. We need to support the heart with some support, 2 liters. However, taking care of the hypoxemia can actually overcome the cardiovascular compartment of the shock. On the other hand, I think here we need to be more susceptible or more sensitive to the risk of a thromboembolic event. We're learning that those patients have some tendency, and prophylaxis therapy of those blood clots that can occur is something that we need to be more susceptible than other patients. So we are learning the nuance of the therapy as we go. And definitely, this is a new disease that started 4 months ago. However, the amount of medical information already exists on it is above and beyond because of the magnitude of it. And the changes that we see is on an immediate level. I think we see it on a daily basis, that we're learning more and more. And I feel that already we're giving superb care to the patient and the best chance to overcome their illness.
This is a slightly tangential question, but I'm curious whether or not you feel, because of the scale and the scope of what's happening, are we learning as well a lot? Maybe, or are we taking away something more general, hopefully, about how viruses and viral diseases affect the cardiovascular system that we didn't really understand before, and maybe that can be applicable to larger arrays of treatments for other things down the road?
You are so right. I think when, the way that medicine profession always learn is collect cases together and lump them. From one case report, we do a case series. From a case series, we do a study. We try to lump cases that seem to behave similarly. Here, we didn't have the opportunity to do a single case. We just have all of them coming out in one time. So we just need to open our eyes very clearly and identify what you mentioned in the beginning, very, very correct. What are the patterns? This is going to be the key to successfully treat those patients. Can we identify which patient is at high risk to deteriorate? Can we identify which patient is at high risk to do the cytokine storm that we need to address the inflammatory system mostly with inflammatory medication, anti-inflammatory medication? Or we need to identify the patient that's going to have a myocardial involved myocarditis and virus, and we need to do more antivirus medication. Can we identify which patient we should be relaxed and send them home from the emergency department and tell them, your symptoms seems to be modest right now, but we are not concerned. It doesn't seem to be that they will deteriorate. Or this is a patient who will say, your symptoms seem to be modest right now, but we want you in the hospital because we think there is signs that will tell us that in the future you may have this course disease. I think those are the element that we are forcing to do right now. The coronavirus have specific feature, but it's applicable, definitely applicable to other viral disease. And I think the lesson that's going to be learned here is going to be enormous, because the medical community and the academic community investing huge effort in order to do the right research. And I have to admit that just to see the amount of research coming up like on a daily basis right now, it's so impressive. And we know that every day we're becoming better.
Yeah, I mean, it is astounding, actually. It's a little bit of a testament to really what we can accomplish when we put our minds to it, right?
Exactly.
I do have one more question. And when you were talking about different medications, I noticed that a lot of the cases that you presented in this paper were the patients were given hydroxychloroquine. And I know there's some question about whether that's good for patients who have cardiovascular disease. Where do you kind of fall on that? Like in the cases that you presented, it seemed like, at least if I can recall, a couple of them did a lot better with it. So is this just we have no idea yet, or like, what's going on with that?
I think it's very important to say, first of all, we don't have idea yet. The data on the hydrochloroquine, of course, started from the Petri dish or the basic science behind it, but it's continued with two studies, one that came from China, the other came from France, and each one of them gave us a little bit different results. One of them were more optimistic from France, and a study from China did not show any differences. Both of them were very small studies. So I think we in medicine in general and in cardiology in specific believe in evidence-based medicine. We believe that we want to do a randomized study that test one medical approach compared to the other and see which one is superior to the other, while we didn't choose a priority who will get those therapy. I think we need to be very careful reviewing cases, because all the time there is some bias to describe the case that were successfully done. But what really success here? The success was that we gave the patient a balloon pump, and also she received a hydrochloroquine. Is this what helped this patient more? I don't know.
Right.
I will tell you something. I will be very cautious right now to say that there is any proven benefit. The data is lacking, and we are eagerly want to see some data coming from more robust studies conducted in Europe, in the USA, in order to understand what is the real role. In every patient specifically, there is a pendulum, an evolving thing. We have a lot of antiviral therapy that we're trying to give that is part of clinical studies that we are conducting in our medical centers, side by side with anti-inflammatory. So each patient is differently. I think that, it was just a coincidence that half of the cases here receive it, half did not. But I would be careful to have any conclusion about it. And me personally, my opinion is still standing that I want more data.
Of course, we always need more data. I mean, it's difficult though, right? Because people are desperate to try something that they think might work. And
Yes, but there is also a danger. So yes, we definitely want something that may be working, but we need to remember that every medication may have some adverse event. In this specific medication, we're talking about adverse event that can be hallucination, and we can talk about adverse event that can associate with cardiovascular system. What we're all talking about is the increased risk of arrhythmia due to prolongation of the QT. So of course, if we choose to give this medication to someone, we need to monitor this patient and to make sure the appropriate precautions are being done. But again, data is lacking, and we will continue to wait to the real study that will tell us whether hydrochloroquine work, yes or not, and if it's working, and what dose, how long. There is so many questions. So every medication, it's not only yes or no, it's to whom and when and how.
okay, I have one last quick question, and I'm not sure if you can answer this or not, but I have heard that you are working very hard with the patients that you've seen in New York to sort of sort out the patterns of what types of symptomology that you're seeing. But I have heard that in other parts of the country and in Italy, that some of these patterns are different. And I'm wondering what you are hearing from your colleagues in different parts of the country in terms of like how these things may or may not be the same or different, and what you think that means.
So first of all, I will tell you something. One of the most amazing things that happened, medicine was also always a very collaborative word effort, but this time even more. We had a meeting with our colleague from Italy. We had a meeting with our colleague from California. We are trying to communicate all across and to see how different patterns behave. You are right. It seems to be that there is different thing that we don't understand if it's really the patient are different, patient population. Is it the medical system and the medical approach is different? And I think this will be only in a retrospect when we will all be in the aftermath, we will be able to understand what was so different, why Germany have such a low mortality rate, why
Right.
other countries have Italy have such a high mortality rate. Is it associated with the amount of testing? Is it associated with the age of the population? Is it associated with the medical therapy that was given? What was very surprising to me every time that I'm talking to my colleague across the globe is that I'm learning something different. Each one of us is still doing things that are different. We are reaching out on a daily basis, and we've been reached out by others on a daily basis to learn our experience, and we will continue to share our experience. And I have to say that this just show and demonstrate how we all in it together. And again and again, I would say the medical community have a different ties into it, and this make it much stronger. So in this question will be probably better answered in the aftermath.
Yeah.
But in the meanwhile, the collaboration across the countries is what impressed me the most.
Yeah, and it underscores the importance of it, I think, as well.
Definitely.
These are scary and also, I think, really fascinating and exciting times to be in medicine, I think, and to be talking about like the research that's going on. So it'll be super interesting to sort of see how this all shakes out in time, and what the profits are from our hard work.
I have to say, this is to be a physician, to be a nurse practitioner, a PA, or any healthcare. This is our privilege. It's a privilege to be involved in patient care, but this is also our responsibility. Right now, it's our responsibility to try to contain, explain, and treat all those patients. It's as you said, it's a scary time in one hand, but this is our time to get all whatever we can do and give. and give and give and give. And only when you give, you find yourself. So I think we as the healthcare provider are finding ourselves on a daily basis right now. And hopefully this privilege that we have every day to touch patient life, we don't take it easily, and we look at it. It's our responsibility right now.
Oh, well, thank you very much for your time, Dr. Uriel. That was a fascinating conversation, and I really appreciate it.
Thank you very much, Gretchen, and keep it safe.
I will. You too.
Bye-bye.
Bye.